Welcome back to the deep dive. Today, we're doing things a little differently.
That's right.
Usually, we take a broad topic and, we wander through it, but today is a mission. We've got the standard texts in front of us, and we are going to do a high-yield revision session on mandibular fractures.
Exactly. This is for the plastic surgery resident 100%. If you're prepping for the FRCS, the American boards, whatever it is,
Yeah.
this is your audio flashcard.
No wishy-washy overview. This is a targeted breakdown, anatomy, classification, management.
We're going to hit the high points.
And we're going to be efficient. So before we start, if you want more of these revision topics, hit that follow button now. And this is important. We're sticking to the theory here.
Right, board facts.
But if you want to see how this plays out for real, you need to subscribe to our premium feed.
That's where we do the journal club and the clinical cases. That's where we get into the, okay, the book says this, but the patient looks like that.
The real world stuff. So for that, get the premium subscription. And please leave us a comment. Tell us what revision topic you want next.
Hand, breast burns. Let us know.
All right, let's do it. The mandible, anatomy and epidemiology.
So let's start with the bone itself. The mandible is, well, it's strong, obviously. It has to be. But it isn't uniform. It has these structural weak points.
The old chain is only as strong as its weakest link idea.
Precisely. And the weak links are all anatomical. You've got foramina, the holes where nerves pop out.
So a hole in the armor?
A literal hole in the armor. Then you've got the teeth, the long canine roots, the impacted wisdom teeth. They create these natural stress risers in the bone.
So if a resident gets that multiple choice question, what is the single most common fracture site? What's the answer?
The condyle. No question. It's around 36%. It acts almost like a safety valve for the skull. It snaps to protect the cranial base.
Okay, condyle's number one. Who's the runner-up?
The body at about 21%. And right behind that, the angle at 20%.
And the angle makes sense because that's where the wisdom teeth usually are.
Exactly. An impacted third molar is a huge weak spot. That's a classic board question correlation.
So condyle, body, angle, the big three. What about the rest?
Then it drops off quite a bit. You got the parasymphysis at about 14%. Then the really rare ones are the ramus and alveolus, 3% each.
Okay.
Coronoid is 2%. And the symphysis, the dead center midline, is surprisingly rare, only about 1%.
You can't really talk about these without talking about the shape of the bone itself. It's a U-shape, a ring, really.
The double fracture rule. It's fundamental. Think of a pretzel. It is very, very difficult to break a rigid ring in just one spot.
The force has to go somewhere else.
It has to dissipate. So statistically, double fractures are way more common than single ones. If you see one, you are obligated to find the second.
What are the classic patterns they need to know?
The guardsman's fracture. Everyone learns this one. A soldier faints on parade, lands on their chin. That force hits the symphysis.
Then travels back?
Right back along the arch and snaps both condyles. Yeah. It's the classic bilateral condylar fracture from a central blow.
And if it's a punch to the side of the jaw, say the left body?
You must look at the other side, the contralateral side. Usually it's the subcondylar region on the right. The force travels diagonally.
It's a reflex. See a body fracture, check the opposite condyle.
Immediately.
Okay, let's shift to classification systems. This is pure exam fodder. Let's start with open versus closed.
This is a classic trap. In, say, a tibia fracture, open means bone sticking through the skin.
A compound fracture.
Right. But in the mandible, it's much more subtle, and it's all about the mouth.
The oral environment.
Exactly. An open mandibular fracture is any break that communicates with the skin or the oral cavity. So, and this is the key bit people miss. That includes any fracture that runs through a tooth socket.
So even if the skin is intact, if that fracture line on the scan goes through the periodontal ligament.
It is an open fracture. Full stop. Bacteria have a direct highway from the mouth down to the bone. Your whole management changes right there.
Okay. What about the named classifications? Dingman and Natfig.
Sounds complicated, but it's the easiest one. It's just anatomical. You name the region. Symphysis, body, angle, ramus, condyle. Purely descriptive.
Got it. The next one needs some physics. Fry's classification. Favorable versus unfavorable.
This is critical for deciding how to treat it. The mandible is suspended in a sling of powerful muscles. Fry's classification asks a simple question. When those muscles pull, do they push the bone fragments together or do they pull them apart?
So a favorable fracture
is one where the muscle pull actually helps you. The muscles contract and compress the fracture line. They splint it for you. It's inherently stable.
And unfavorable is the opposite.
The muscles are your enemy. They're pulling the
Sure.
fragments apart, widening the gap every time the patient swallows. You can't manage that conservatively. It'll just keep displacing.
Which brings us to the third one, Kazanjian and converse. This is all about the teeth.
Right, because the teeth are our guide. Our goal isn't just bone healing, it's restoring occlusion, the bite.
So what are the classes?
Class 1 is the best case. You have teeth on both sides of the fracture. You can use them to lock the jaw into place. Class 2, you only have teeth on one side.
You've lost half your map.
You've lost half your map.
Yeah.
And Class 3 is the nightmare, edentulous. No teeth on either fragment.
How do you even align that?
With great difficulty. You lose that locking key mechanism. You have to rely purely on getting the bony anatomy right, which is much harder.
That's a perfect lead-in to management principles. The number one goal is
Restoration of pre-injury occlusion. The patient must bite down exactly as they did before the injury. If the bite is off, it's a functional failure.
and timing. Can this wait?
Not really. The recommendation is treatment within 48 hours. The longer you wait, the harder it gets. The muscles shorten, tissue gets fibrotic. It's a real struggle to reduce it.
And we mentioned infection, so antibiotics are standard procedure.
Absolutely. Perioperative antibiotics are required, and early mobilization is key. A stable fracture is much less likely to get infected.
Let's talk about the treatment options then, starting with the most conservative. When do you just not operate?
Masterly inactivity. It's the exception, not the rule. It means a strict non-chew diet for 4 to 6 weeks, puree and fluids only.
Who's a candidate for that?
A very specific patient. It has to be, say, a green stick fracture or a totally undisplaced favorable fracture. And this is crucial. The patient's occlusion has to be perfect. If the bite is off at all, you can't just watch it.
Okay, next step with the ladder, intermaxillary fixation, IMF, wiring the jaws shut.
That's pretty much it. We use the upper jaw, the maxilla, as a splint for the broken mandible. We attach arch bars or screws to the teeth and then wire them together.
So the patient literally can't open their mouth.
Correct. The mouth is shut to immobilize the bone. We use it for certain condyle fractures or for kids or maybe some minimally displaced favorable fractures.
How long do they stay wired?
Usually 4 to 6 weeks in an adult.
That sounds awful. What are the downsides?
Oh, there are many. It's not rigid, so there's still some micromovement. Hygiene is a nightmare. Patients lose weight. And the stiffness, the trismus, when the wires come off, can be terrible.
And there's a huge safety issue, isn't there?
The airway, that's the big one. If a patient vomits when they're wired shut, they can't clear it, they can aspirate. It's a life-threatening emergency.
I've heard you literally give them wire cutters.
It's not a story, it's a standard protocol. You hand the patient and their family wire cutters, and you teach them how to cut the vertical wires in an emergency. It's a key safety point for exams.
Wire cutters in the pocket. Okay. Let's move to the gold standard, ORIF, open reduction and internal fixation.
This is what we do most of the time now. Open it up, put the bones back, and put a plate on. We actually still use IMF during the operation to set the bite perfectly.
How do you get to the bone without leaving a huge scar?
Mostly through the mouth. The intraoral approach is the workhorse, no facial scar. If we have to go from the outside, we hide the incisions. Under the chin, in a neck crease, we're pretty good at hiding them.
All right, now for what I think is the most critical part for the boards, the biomechanics. Load bearing versus load sharing.
If you learn one thing from the surgical section, it's this. You have to decide, is the plate going to do all the work, or is the bone going to help?
Okay, define load bearing.
Load bearing means the plate takes 100% of the force. The bone is doing nothing. You use this when the bone is shattered, comminuted, or if there's a gap. You're building a bridge.
And that bridge needs to be strong.
Very strong. So you're using big locking reconstruction plates.
Yeah.
And critically, bicortical screws. The screws have to go through both cortices of the mandible to get enough grip.
And load sharing?
Load sharing is partnership. The stability comes from friction between the bone ends plus the implant. This is for a simple, clean break. You press the bone ends together and the bone itself shares the load.
So you can use lighter hardware.
Much lighter. Miniplates and monocortical screws. You only need to drill through the outer cortex.
This sounds like Champy's principles.
Exactly. Champy figured this out in the 70s. He described the ideal lines for plating. He realized you just needed to put a small plate along the tension zone near the top of the mandible, and it would work like a tension band.
Minimalist and effective.
Precisely. It uses the physics of the jaw against itself.
A quick safety note on drilling. Where's the danger zone?
You have to avoid two things. The mandibular canal, which has the nerve for your lip, hit that, and the patient has a numb lip forever. And of course, the tooth roots. Hit a root, you kill the tooth.
Let's talk about the big controversy, condylar fractures.
Ah, yes. The great debate. It's all about anatomy versus function. The condyle is in the jaw joint, the TMJ, and the big fear is ankylosis.
A fused jaw.
Fused jaw. It's a disaster. If you operate in there and cause scarring, or if you immobilize it for too long, the joint can fuse solid.
So a lot of surgeons prefer to stay out.
Right. Conservative management is very common. Soft diet, physio, or maybe IMF with elastics instead of wires to allow a little bit of movement.
So when do you have to operate? What are the
Well,
absolute indications?
4 you need to memorize. 1, IMF is contraindicated. The classic example is a patient with epilepsy. You cannot wire an epileptic's jaw shut.
Clear. What else?
2, closed reduction fails. You try to fix it without surgery and the bite is still wrong. 3, the condyle is dislocated up into the middle cranial fossa,
Into the brain space.
into the brain space. And 4, a lateral extracapsular fracture dislocation. Basically, the bone is so far out of place you have to go in and get it.
Okay, last special group, kids. Pediatric fractures.
They're a minefield. Their bones are full of 2 things you hate to drill into: active growth centers and unerupted tooth buds.
If you damage a growth center,
The jaw stops growing on that side. You've created a future facial asymmetry problem. If you drill a tooth bud, the tooth never comes in.
so the rule is,
Avoid the drill if you can.
Hmm.
Most pediatric fractures are treated with closed methods.
give me the rapid fire breakdown by age. Under 2,
Splint only. Don't even try to wire them.
under 4,
IMF, but for a shorter time, 2 to 4 weeks. They heal incredibly fast.
under 8,
You can use the deciduous, the baby teeth, to anchor your wires.
and over 9.
They start to act more like adults, so you can treat them similarly.
What about the remodeling potential of the pediatric condyle?
It's almost magical. In a preteen, you can have a condyle fracture that looks awful on an x-ray. But if you just get them back into occlusion with a short period of IMF-like, 7 to 10 days, the body will completely reshape that bone back to normal.
So just get them moving and let nature do the work.
Don't operate on a pediatric condyle unless you have no other choice.
We've covered a ton of ground here.
We have. But if I can just re-emphasize one thing for any exam, it's that load-bearing versus load-sharing concept.
Ah,
Know why you're choosing a big plate versus a small plate.
good point. Okay, here's a final thought to leave everyone with. We barely mention external fixation. The text says it's rarely used, maybe for severe osteomyelitis or massive defects.
It's the lifeboat option.
It is. But think about it. In our world of 3D printing and free flaps, does the X-Fix still have a role? If you're in a resource-poor setting or dealing with a jaw that's just rotting away from radiation,
Then knowing how to put on that external frame might be the one thing that saves the day when all the fancy stuff fails.
it's a lost art, almost. But it's worth keeping in the back of your mind.
Absolutely. The option of last resort.
And that's a wrap on our revision deep dive. We hope this helps you crush those boards.
If you found this useful, please do rate and review the show. It really helps other residents find us. And for the Clinical Cases and Journal Club, you know what to do.
Get that premium subscription. Thanks for listening. We'll see you on the next deep dive.